Welcome! Today, we explore a real-life medical case where clinical reasoning meets real-world challenges. Every symptom has a story, and every diagnosis is a puzzle. Let's analyze this case and connect it with the insights from Harrison's Principles of Internal Medicine.
Life is predictable, a routine, a rhythm, morning tea, a short walk, a peaceful evening. For her, today was just another ordinary day, until a simple stomachache. Nothing alarming. Or so she thought. It's just a stomach infection. Some antibiotics, plenty of fluid. You'll be fine. But the bacteria inside her had a different plan. And in just 3 weeks, everything changed. It started subtly. A weakness, a slight unsteadiness. But by morning, she could barely stand. By the time she reached the hospital, her body was failing her. Bilateral limb weakness, reflexes. Could be a stroke. A mystery was unfolding. Stroke, a neurological disease, or something far worse? This isn't just Guillain-Barré Syndrome. It's fulminant, the rarest and deadliest variant. Intubate, start 4 immunoglobulin. Standard treatment began, but instead of improving, she spiraled, her heart's failing. Push vasopressors. Now! Despite everything, her body was shutting down. Within 48 hours, we lost her. But why? What had triggered such a violent Campylobacter jejuni? It was in her system. It tricked her immune system into destroying her own body. A fatal mistake, and she was not alone.
Presents a unique challenge, unexpected symptoms, critical decision-making, and the importance of early recognition. To understand it better, let's turn to Harrison's Principles of Internal Medicine and explore Guillain-Barré Syndrome.
Wide at a rate of 1 to 4 cases per 100,000 people per year. Males are at a slightly higher risk than females, more common in adults than children in Western countries.
Clinical manifestations of GBS. The hallmark of GBS is rapidly evolving weakness with areflexia. The weakness starts in the lower limbs, often described as rubbery legs, and ascends upward. Arms then become involved, showing difficulty in lifting objects. Facial weakness is seen in half of the cases. Cranial nerve dysfunction may occur. Bulbar weakness leads to difficulty swallowing and handling secretions. Neck, shoulder, or back pain occurs in nearly half of cases. Severe cases require ventilatory support in 30% of patients. Autonomic dysfunction can cause postural hypotension and arrhythmias. A key red flag is the absence of fever or systemic symptoms at onset.
Clinical features and causes of Guillain-Barré Syndrome, GBS. Deep tendon reflexes become absent or reduced within a few days. Mild loss of pain and temperature sensation can occur. Proprioception is more affected, leading to impaired coordination. Bladder dysfunction is rare but can occur in severe cases. Different forms of GBS, sensory forms in GBS with severe bulbar and facial weakness, associated with CMV and anti-GM2 antibodies. GBS often follows an infection, occurring 1 to 3 weeks after an acute illness. The most common bacterial trigger is Campylobacter jejuni. Other viral causes include cytomegalovirus, CMV, Epstein-Barr virus, EBV, HIV, hepatitis E, and Mycoplasma pneumonia. In rare cases, vaccines such as the swine flu and meningococcal vaccines have been linked to GBS. GBS is also seen more frequently in patients with autoimmune conditions like SLE, lymphoma, and HIV. Pathophysiology of Barre Syndrome, GBS. GBS is an immune-mediated attack on the nervous system, specifically the peripheral nerves. The immune system mistakenly identifies nerve gangliosides as foreign antigens and attacks them. Autoantibodies attack gangliosides such as GM1 and GQ1b, leading to nerve damage at the nodes of Ranvier, resulting in conduction block and paralysis. In the AIDP form, immune cells destroy the myelin sheath, slowing or blocking nerve conduction. In axonal forms of GBS, the immune system directly attacks the axons, leading to longer recovery and possible residual disability. If myelin is damaged, recovery is faster due to remyelination. If axons are damaged, recovery is slower and may require regeneration. Understanding the pathophysiology of GBS helps in early diagnosis and targeted treatments.
Suspected GBS cases. The hallmark finding in GBS is albuminocytologic dissociation, high protein levels without significant white blood cell elevation. Nerve conduction studies and electromyography help confirm GBS by assessing nerve function. Typical findings in GBS include reduced CMAP amplitudes, slow conduction velocity, conduction block, and temporal dispersion. CSF analysis and electrodiagnostic studies are crucial for diagnosing GBS early and guiding
Treatment of Guillain-Barré Syndrome, GBS. Several conditions can mimic GBS and should be considered in the differential diagnosis. Acute myelopathies can present similarly to GBS. Diphtheria can cause neuropathy and weakness. Lyme polyradiculitis can present with neurological involvement. Poliomyelitis, caused by the poliovirus, leads to flaccid paralysis. Porphyria, a metabolic disorder, can cause neurological symptoms. Tick paralysis results from neurotoxins from tick bites. CMV polyradiculitis occurs in immunocompromised individuals. The mainstay of treatment for GBS includes IVIG and plasmapheresis. Plasmapheresis, or plasma exchange, is another effective treatment option. Glucocorticoids are not effective in treating GBS. Treatment should begin as soon as possible if there is progressive weakness. If the disease has plateaued, treatment is not always needed unless severe. Supportive care is essential, especially in severe cases requiring ICU management. Early intubation is required if respiratory failure is imminent. Preventing complications is key. This includes DVT prophylaxis and nutritional support. Early recognition and treatment of GBS, along with comprehensive supportive care, improve patient...
Guillain-Barré Syndrome. Conclusion. Guillain-Barré Syndrome is a life-threatening, yet potentially reversible condition if diagnosed and treated early. Always consider GBS in patients with rapidly evolving weakness and absent reflexes. Timely intervention with IVIG or plasmapheresis can save lives. Early recognition and treatment are key to improving patient outcomes in Guillain-Barré Syndrome.
Conclusion and call to action. Medicine is a continuous learning process where clinical experience meets evidence-based knowledge. If you enjoy case-based learning with references from Harrison's, stay connected for more insights.